Good morning. Thanks for being here. Thanks to our sponsor, Edwards Life Sciences and Octo Pharma. So my pleasure this morning. This is the first of our grand rounds with our fellows. Two of our third year fellows will be presenting this morning. Both have been great. Really tried to learn cardiology, thoughtful, hardworking. So I really couldn't ask for more. I'll present both of them and then I'll let them speak. So Kevin Buda is a native of Minnesota, University of Minnesota for med school, University of New England for med school, did residency at Hennepin, and as I mentioned, third year fellow looking at critical care. So he's interviewed at all the top spots in the country and finds out tomorrow, right, where he's going to end up for critical care fellowship, and also looking at where he's going to go the following year. So he has distinguished himself in both research and teaching. He's published over 30 manuscripts in critical care cardiology, including recently presenting in Greece with Kasha. He, most of the papers on pulmonary embolism, cardiogenic shock, etc. He's also been a great mentor for trainees. He's reviews for journals and has been a very hardworking fellow. As I mentioned, he has a young son and loves the outdoors, loves archery and hiking, and he'll be presenting on shortness of breath, out of time, pulmonary pitfalls, and cardiogenic shock. Dr. Krishna Prabhu is a native of Iowa, went to Harvard for undergrad, did a master's in public policy at Oxford, went to Harvard for medical school, University of Washington for his internal medicine training. He married a woman from Minnesota, and they worked as hospitalists in Duluth and at Red Lake Reservation, spurring this morning's topic. And we are really excited that he will be joining us next year, with Dr. Stockman and Dirks and Baxter and Crosby. I should mention both fellows passed their ECHO boards. Dr. Buda is a member of our Jeopardy team, which will be representing us nationally. So without further ado, who's speaking? Dr. Buda will be going first.
All right, can everybody hear me okay? Perfect. Wonderful. Well, thank you for the introductions. I'm very pleasantly surprised to see the number of people that are here with this temperature after a holiday weekend, so I appreciate you all being in attendance. Wanted to talk about some pulmonary complications that come up in the setting of cardiogenic shock. And I thought the best way to start would be to at least mention the SCAI shock classification. Most of you will be familiar with this. For those of you who are not, cardiogenic shock exists on a spectrum anywhere from at risk of cardiogenic shock or SCAI stage A to in extremis or SCAI stage E. And the point of this slide is that there's a stepwise increase in mortality as you go from one SCAI shock classification or one SCAI shock stage to the next. You get some pretty interesting insights when you look at movement between groups, especially over the course of the hospital stay. So this is data from the Cardiogenic Shock Working Group, and they looked at movement between groups, and I want to draw your attention to, can you see my pointer here? Perfect. So if I can draw your attention to people that came in at SCAI stage B or beginning cardiogenic shock, substantial portion of those patients decompensate to SCAI stage D, cardiogenic shock, by 24 hours. Similarly, if you look at SCAI stage C, cardiogenic shock on arrival, a substantial proportion of those patients will decompensate within 24 hours. So the point of this slide, at least for the purposes of this talk, is that it's very common in cardiogenic shock. In fact, more than 50% of patients that present in CS will decompensate within the first 24 hours. And so decompensation in cardiogenic shock is really the rule rather than the exception. And if you are taking care of patients in cardiogenic shock, you should expect them to decompensate. When they decompensate and they do not survive to hospital discharge, what do they die from? This is data from CTTN that looked at cause of mortality, and 2/3 of patients are dying from cardiogenic shock. 1/3 of patients are dying from other issues. What about our own institutional experience? We looked at all of our VA ECMO patients from 2011 onwards. So this was VA ECMO for any cardiogenic shock indication. This was AMI cardiogenic shock, decompensated heart failure cardiogenic shock, and post-cardiotomy shock. And the variables here don't matter, but the thing I want to draw your attention to is the groups. So we looked at who died before versus who died after decannulation. And the size of the group that died after decannulation should be intuitively or inherently surprising to people. These are people that were, this was not palliative decannulation. These were people that were improving from a hemodynamic standpoint. And despite that hemodynamic improvement to the point where they were able to come off of ECMO, they still died during the course of their hospital stay. So what did they die from? A third of them died from multisystem organ failure. That was predominantly renal, cardiac, which was right ventricular failure, and respiratory failure. A third of them died from shock, which was predominantly infectious shock. And about a quarter of them died from neurologic complications, which was a mix of anoxic brain injury and stroke. So the point of the first few slides here was just to illustrate, number one, the mortality for cardiogenic shock is very high. Two, most patients that present in cardiogenic shock will decompensate over the course of the first 24 hours. And three, a lot of the patients that die after decompensation are dying from non-cardiovascular issues. And so if we're trying to move the needle in cardiogenic shock, we really do need to think outside of the pericardium. So that's our segue to managing the lungs when the heart fails. This will be broken into three sections. Number one, PEEP, or positive airway pressure. Number two, oxygenation targets. And number three, sedation. So the underlying theme for this talk is that there's kind of a magical Goldilocks zone. And I think people in certain areas intuitively understand this in physiology. Too low can be bad and too high can be bad. But in other areas, I think we're apt to forget this. Things like hypothermia or temperature, hypothermia bad, hyperthermia bad. Things like blood pressure, hypotension is bad, and hypertension is bad. But I think a lot of people may see an ABG like this and not look twice at the PO2 of 246. That's severe hyperoxia. That's actually a very bad prognostic sign and one that I think we don't think enough about. Similarly, this is a ventilator in somebody with AMI cardiogenic shock and COPD, and their tidal volume, their I to E ratio, and their PEEP is at the bottom there. And those are inappropriate settings for this patient, at least given the limited data and information I gave you. So let's start with PEEP. This is a very simplified, almost cartoonishly simplified diagram of what happens with filling pressures in the heart as a function of different PEEP levels. But I started with it because I think this is how a lot of people think about escalating PEEP. This is a study that looked at 5, 10, and 15 of PEEP and just what happened to the filling pressures, the mean PA pressure, the pulmonary capillary wedge pressure, and the CVP as a function of increasing PEEP. And all of those filling pressures went up and the cardiac index went down as you escalated PEEP. So I think it would be easy to look at data like this and say PEEP is bad in cardiogenic shock and you should try to minimize this. But this is inappropriately ambivalent to two different issues. Number one, it's ambivalent to what else is going on in the body, what's happening in the lungs, are there any extremes of physiology that we need to take into account? And number two, where is the actual issue? Are we talking about LV predominant shock or are we talking about RV predominant shock? And we'll go over examples of those. So this is a schema that I like a lot. It has lung volume on the bottom, but you can replace lung volume with PEEP. It's the same conceptual framework. There's a lot of patients that we take care of that are really on the left side of this curve. They are post-arrest cardiogenic shock patients, for example. A lot of them haven't been breathing for 30, 60 minutes. A lot of them have alveolar collapse and atelectasis. And those are patients for whom you should really think of, or at least I think of the alveoli like a balloon. It's hardest to open the balloon right at the beginning, and then it gets easier and easier the more you inflate it. And in the setting of an atelectatic patient with alveolar collapse, they actually need higher PEEP to open those alveoli. And so with higher PEEP levels, you're actually going to open the alveoli, you're going to get less hypoxic vasoconstriction, and your pulmonary vascular resistance is paradoxically going to fall as a result of increasing positive airway pressure. There's a Goldilocks zone beyond which, if you continue to escalate PEEP and lung volumes, you're going to get compression of the pulmonary vessels, and as a result of that, your pulmonary vascular resistance can rise again. So we're trying to manage the balance between antalect trauma on one side and barotrauma on the other side. This is a example of ultrasound of a patient's lung that was a post-arrest patient. Just to editorialize for a little bit, I feel like we appropriately spend a lot of time on cardiac ultrasonography, and to me, that's a very high cognitive lift to understand cardiac ultrasound, and it's very difficult to do. I think in contrast, lung ultrasound is very easy and you can learn it very quickly, and especially in approaching an undifferentiated hypoxic patient, gives you really useful information pretty quickly. And so understanding, do they have A lines, do they have B lines, do they have sliding sign, is there consolidation, hepatization, a pleural effusion? Anybody in this room could learn how to do that and answer those questions with an hour of training, and they can be really useful. So this is a patient with a lot of atelectasis and also a pleural effusion. And somebody for whom, this was a post-arrest patient, and somebody for whom a lower PEEP setting may not be appropriate, or at least optimal. And I'm watching all of you carefully. I can tell that you're all thinking, this is great, this is human physiology, but what about cardiogenic shock in female pigs? I will go over that data for you. I don't usually do animal data, but I thought this was such a cool study, and it was just published a couple weeks ago in Anesthesiology, so I wanted to include it. What they did is these were all intubated pigs, and they did a complete set of hemodynamics at different PEEP levels for every pig. And so they did escalating PEEP of 5 all the way up to 15 millimeters of mercury under normal physiology, and then they induced LV predominant cardiogenic shock by injecting alcohol into the LAD, and when there was a 30% reduction in the cardiac output, they repeated that entire set of hemodynamics at those different PEEP levels. They then waited an hour and repeated hemodynamics. So they got to see the effect of PEEP under normal physiology, early cardiogenic shock, and late cardiogenic shock using patients as their own controls. And I should have given a trigger warning before putting up pressure volume loops, but for those of you who are not staring at these very often, this is volume on the x-axis and pressure on the y-axis. So here, this is the cardiac cycle. And so here we have an increase in pressure without changing the volume. So this is isovolemic contraction. Here the aortic valve opens and we're ejecting blood. Here systole ends and diastole starts. And here we are relaxing without a change in volume. So this is isovolemic relaxation. Here the AV valves open and we're filling the ventricles. And here's end diastole. So we have end diastole here. This is our end diastolic volume. This is our end systolic volume. So the space between those, this horizontal line, is our stroke volume. And so what you can see as you go from PEEP of 5 to 10 to 15, or red to green here, is that in normal physiology, the end diastolic volume goes down substantially, the end systolic volume goes down substantially, and our afterload goes down. So rather than memorizing this, how I think of this physiologically is we're giving positive airway pressure, and so our pulmonary vascular resistance is higher. As a result of the pulmonary vascular resistance being higher, we have less preload getting over to the LV. And as a function of less preload in the LV, our end diastolic volume is going to be lower. We also have a lower afterload, and so per unit preload, we're ejecting more blood. And so our end systolic volume is also going to be lower. So the curve shifts to the left and it shifts down. A is in normal physiology and B is in cardiogenic shock here. Excuse me. Most of these variables that they looked at are for research purposes. These are not things that we use clinically, but the stroke work does go down substantially when you go from 5 of PEEP all the way up to 15 of PEEP. The stroke volume, there's probably a mild reduction in stroke volume. The LVEF goes up. And systolic pressure goes down substantially. The LV wall stress and the myocardial oxygen demand also go down substantially as you go from 5 of PEEP all the way up to 15 of PEEP. Black here is normal physiology and red is cardiogenic shock, and the stroke volume goes down, or stroke work, excuse me, goes down, and the cardiac efficiency goes up as we get to higher and higher levels of PEEP. So I wanted to put this back up and really contrast it against what we know about invasive hemodynamics with temporary mechanical circulatory support. I really think, or at least I conceptualize PEEP in the setting of LV predominant cardiogenic shock as a weak afterload reducing device and a weak LV venting or unloading strategy. So that's LV predominant shock. In the setting, we kind of briefly mentioned the RV, but when you're giving positive pressure ventilation, you're increasing the pulmonary vascular resistance, and you're decreasing the preload on the right side of the heart. And so normally there is anywhere from a 4 to 8 millimeter mercury gradient between the systemic veins in your right ventricle. So when somebody has RV predominant shock and you're giving positive pressure ventilation, it doesn't take much to decrease that gradient. So in RV predominant shock, you're decreasing venous return with PEEP, and you have a compensatory increase in your systemic vascular resistance. So PEEP is really not your friend with RV predominant shock, and I would really broaden that to anything that's preload dependent, so a restrictive cardiomyopathy, a cardiac tamponade, et cetera. In LV predominant shock, that's the curves that we just looked at that shifted to the left and down. So we have lower RV output, that means lower end diastolic and end systolic volume. We have decreased afterload and a decrease in myocardial oxygen demand. So really the effect of PEEP on cardiac hemodynamics and stroke volume, et cetera, depend on where the issue is. So moving on from PEEP, what mode of invasive mechanical ventilation do we use is beyond the scope of this talk, but I just at least wanted to mention that there are different modes of mechanical ventilation that have higher afterloads. And so modes like SIMV is a form of spontaneous ventilation where people are breathing on their own, they have higher blood pressures. So we should just know that when we're managing patients in the CICU to talk to whoever's managing the ventilator and say, hey, we wanna use a form of mechanical ventilation that has lower afterload. What do we know about oxygen? So this is not cardiogenic shock. This is post-arrest. This is a meta-analysis on the effects of hyperoxia. And this curve on the left should look familiar to us. This is basically superimposable with the lung volume and PEEP curve that I showed you at the beginning. It's pretty small text, so for those of you who can't see, we have admission PaO2 on the x-axis and in-hospital mortality on the y-axis. And the leftmost part of this curve is not surprising as we go from hypoxia to normal oxia with a PO2 of 100 here. Our in-hospital mortality goes down. That makes sense. But the thing that may be surprising is that as you go to the extremes of hyperoxia, especially a PO2 of above 200 millimeters of mercury, our mortality increases substantially. And how much does it increase? Well, we have the force plot on the right. Just to give you an example, I don't know why I remember this, but one of the meta-analyses on red meat consumption and CV mortality had an odds ratio of somewhere, it was 1.06 or 1.08. So it was a 6 to 8% increase in your risk of CV events over a particular time period with eating more red meat. And I bring that up just to contrast it. This is an odds ratio of 2.37. So this is a 237% increase in mortality with the extremes of hyperoxia. We don't know enough to know, is this associational or is this causal? There have been no randomized trials obviously in this space, but just to point out that it's at least a marker of increased mortality. What about all comers in the CICU? This is Jake Jenser's work out of C3TN, and he looked at both the prevalence and outcomes as a function of hyperoxia and found that it was very prevalent. It's prevalent in 1 in 5 patients in the cardiac ICU. There's a J-shaped mortality curve, so again, as we go from hypoxia to normal oxia, our mortality goes down, and then as we get hyperoxic, our mortality goes back up. They found same thing, PaO2 of above 300 was associated with the highest risk of mortality. And then this is a cardiogenic shock talk, so they did the same thing again through C3TN, looking at extracorporeal support in patients with cardiogenic shock. And they found that the worse the hyperoxia was, the higher the in-hospital mortality was. And they did subgroup analyses where they looked at every subgroup available and didn't matter, are you male, female, are you white, are you non-white, do you have cardiac arrest, no arrest, medical cardiogenic shock, surgical cardiogenic shock. The worse your hyperoxia was, the light green here is mild hyperoxia and the blue is severe hyperoxia. The worse your hyperoxia is, the worse your in-hospital mortality is. Okay, so we've covered PEEP, we've covered O2 targets, and briefly wanted to mention sedation in cardiogenic shock because I feel like it's a potentially dangerous area. There's only 2 trials I know of in this space. They're peripherally related to the talk at best, but I just wanted to at least mention them so you knew what trials were out there. Just by way of background for this trial, a lot of patients with out-of-hospital arrest and cardiogenic shock, they're really what determines their outcome is their neuroprognostication. And so there's at least theoretic concern in a population that might have a bunch of multi-system organ failure and hepatic dysfunction that may poorly metabolize benzodiazepines. Do the benzodiazepines confound our neuroprognostication and our ability to make a decision and get people the therapy that they need. And so they looked at propofol versus midazolam for this population in terms of time to liberation from mechanical ventilation and ICU discharge. They found no difference between the groups. This is not cardiogenic shock, but this is Killip class 3 MI. So they looked at propofol versus etomidate for induction of anesthesia in patients for whom they had an MI and they're having respiratory failure as a result of their MI. And they looked at, are we having more hypotensive events with propofol versus etomidate? They also looked at in-hospital mortality, and they found less frequent hypotensive episodes with propofol compared to etomidate, and they also had a lower in-hospital mortality in that cohort. This is a very exhaustive list of all of the different sedating medications that we use in the CICU. I'm not going to go over all of them, but I just wanted to mention a few that I feel like are common culprits of hypotension or hemodynamic issues that we should think more about. One is dexmedetomidine or Precedex. Commonly as a culprit of bradycardia in the CICU, so there's really two populations for whom you should be cautious with it. One is obviously the cardiogenic shock population. Cardiac output is stroke volume times heart rate, and so you really tank heart rate at your patient's peril. And the other is the post-cardiotomy population. A lot of conduction system disease in the post-cardiotomy group, and a lot of times where we're trying to decide, does this person need a pacemaker or do they not need a pacemaker? And so for those patients, you really need to be careful with Precedex. It's also something that is, the half-life's about 2 hours, and it tends to be titrated inappropriately quickly, and so it can really stack just like benzos do when we're doing TEEs. Ketamine I just wanted to mention because in the setting of shock, it gives you the gift of arterial hypertension. And so for the people that are hypotensive, you're not sure, will they tolerate propofol, will they tolerate etomidate? From a preload reduction standpoint and a hypotensive standpoint, it can be helpful from that aspect. It doesn't cause hypotension like other induction agents do. It is a mild sympatholytic, and so in patients for whom you're worried about that phenotype where the sympathetic drive is really what's keeping them alive, you need to be careful with ketamine. We're familiar with neuromuscular blocking agents, so we'll skip those. I did want to mention sugammadex. It's really one of those before and after medications in cardiac anesthesia. It's reversal, I believe, of cisatracurium, and it really quickly reverses paralysis. It is extremely effective, and it's quite safe. Despite being quite safe, it is used so commonly that if you're looking for its side effects, you'll find them. And it can cause, rarely, but it can cause a severe hypotensive and bradycardic reaction. I've actually had 2 patients that coming out of surgery, they had a bradycardic PEA arrest, and both of them were shortly after receiving sugammadex. So it's one of those things that unless you're aware of it, you really have to look in the anesthesia flow sheet sometimes to see when they arrested and what medications they received in that peri-arrest period. Unless you're thinking about it, it's something that you could miss. And then anxiolytics and antipsychotics can all cause hypotension. Okay, so in the last few minutes here, how do we put this together? This is more than we'll go over here, but really, you have somebody with cardiogenic shock, they're decompensating from a respiratory standpoint, and how do you manage that in the peri-airway or peri-intubation period? Step number 1, we usually have an echocardiogram at this point, so we have some semblance of, or some understanding of biventricular function. First thing I ask is, do we have some preload dependent state or right ventricular failure? If we do not, and this is pure LV predominant failure and LV predominant cardiogenic shock, if we're doing non-invasive ventilation, anything with positive airway pressure can be really helpful, both from a pulmonary edema standpoint and from a hemodynamic LV centric worldview standpoint. So something like BiPAP rather than high flow nasal cannula can be really helpful. If they do need intubation, shooting for higher PEEP is appropriate and may actually be associated with improved outcomes. So PEEP of 10 to 12 as opposed to 5. And then if they are somebody with RV predominant failure, everything I said is flipped on its head. So PEEP is really your enemy. So something like a high flow nasal cannula rather than a BiPAP would be at least theoretically better. If they do need intubation and you're worried about hypotension during intubation, at least thinking about ketamine or something that's less deranging from a hemodynamic standpoint. if you're even worried about the mild sympatholytic effects of ketamine, something at least bringing up, is this person appropriate for an awake fiber optic intubation, or something where you're not giving them any sedating medications, and then avoiding mechanical ventilation at all costs, but if you need to do mechanical ventilation, minimizing PEEP. Following their ABGs post-intubation to make sure they're not hyperoxic, and then working with whoever is managing the ventilator to make sure we're using a mode of mechanical ventilation that doesn't have high afterload. So where is this heading? I just wanted to mention a couple interesting things that are happening in the registry space. The C3TN, I've shown you a number of their studies already, but the Critical Care Cardiology Trialist Network is led out of the TIMI study group out of Brigham, and they're doing amazing work with really, like I said at the beginning of the talk, looking outside of the pericardium and what are the effects of everything else that happens in the ICU on mortality and cardiogenic shock. The Cardiogenic Shock Working Group is now an international registry that they've done a bunch of things, but really they're second to none in the hemodynamic profiling of cardiogenic shock and the longitudinal hemodynamics of cardiogenic shock. So how do people do over that first golden hour? How do people do over the course of the first day of cardiogenic shock? And can we predict the people that are going to decompensate and require escalating support? They've been an extremely busy group. This is just since 2020, and they got about 1 million results in Google Scholar. And they're actually very interested in having MHI as an enrolling site. And so we've had a couple conversations with Navin Kapoor out of the Tufts group, who leads the working group. And we have funding now for in-hospital abstraction of 100% of our cardiogenic shock volume. So that's the MI cardiogenic shock, heart failure cardiogenic shock, and post-cardiotomy shock. We're currently working on funding for the 1 and 12-month follow-up phone calls. We want to see how people are doing from a quality of life standpoint after they discharge from the hospital. And so the goal of that will be, it'll ideally index our outcomes compared to other centers of excellence across the country. And then numbers 2 and 3 is it'll identify areas of excellence where we're doing an especially good job and can teach other groups, also areas for improvement where we can improve our outcomes. So with that, I will forfeit whatever time I have remaining and open it for questions.
Thank you, Kevin, for that morning conversation and a lot of data. You view the different types of cardiogenic shock in terms. Oh, thank you. Do you view the different kinds of cardiogenic shock that you just listed in terms of the treatment? Are there any particular differences and nuances for the ventilatory management depending on what kind of shock they might have?
Do you mean the like hemometabolic profiles of cardiogenic shock?
No, the cause, acute MI versus post-cardiotomy versus heart failure shock.
Yeah, that's a really good question. The short answer is I don't know the answer to that, and with the literature review for this, I don't know that anybody knows the answer to that. From a first principle standpoint, I think that especially the post-cardiotomy shock population, it's almost like and a lot of the MI shock population, it's almost like the post-arrest population where they have two things going on. They have low cardiac index, but they also have low systemic vascular resistance. And a lot of the variables we talked about play with the systemic vascular resistance. It either increases or decreases it, depending on what settings on the ventilator you're talking about. So from a first principle standpoint, I would think that in those two populations, the people that are vasoplegic, we would have worse outcomes when we're decreasing those markers, but that's a guess. I don't think we have that data. It's also a very nascent field in respect to one of the cardiogenic shock working group publications was the different hemodynamic profiles of cardiogenic shock. So there's a non-congested shock, there's a hemometabolic shock. I think that's interesting from a phenotyping standpoint, but we don't really yet know which interventions match to which profile of cardiogenic shock. And so I think a lot of that's to be determined. Okay, thank you so much.
Thanks so much for, can anyone hear me? Thanks so much for having me. It's a real pleasure to be able to speak to you today about this topic. My name is Krishna Prabhu. I'm a General Cardiology Fellow. And I'll just give you a little bit of background about myself. I I went into medical school with an interest in global health and did my internal medicine training at the University of Washington in Seattle. It serves about a 5-state area, Alaska, Montana, Washington, Idaho. Must be forgetting one of those states. But in any case, yeah, Wyoming. Maybe I don't know if I said it again. But in any case, as part of the medical education, it really involves encouraging folks to practice rural medicine by sending medical students and residents on rural rotations. And so my wife and I, who did residency with me, were able to go to rural Alaska and rural Montana. And through that, I think we're able to be exposed to practicing rural medicine. And following residency, we worked as hospitalists in Duluth, and then both worked at Red Lake Reservation, the hospital there. I was in the hospital working primarily with inpatients, but also on their NSTEMI, STEMI, and stroke clinical decision pathways, which is sort of how this talk and interest was born out. I finished working at Red Lake before starting Cardiology Fellowship, and would just like to talk to you about American Indian cardiovascular health with a Minnesota focus, admitting that this is by no means comprehensive, and that I'm no expert. So my objectives for this talk: first, I'd like to give you a sense of the geography of Minnesota's American Indian reservations. It's a complex one. Talk a little bit about the disparities in cardiovascular disease and burden amongst American Indians. Some challenges I see in preventing and treating cardiovascular disease, and then opportunities and I think assets that the current system has for delivering care. So first, to begin with, this is a picture of every lake, river, body of water in Minnesota to give you a sense of proportion of how large Red Lake really is in comparison. And so that's Red Lake in kind of the far northern area of Minnesota. One of my favorite Ojibwe writers, David Troyer, writes that Red Lake is mostly water. It's a beautiful place unlike any other in America. For starters, upper and lower Red Lake are almost completely undeveloped. Elm, ash, and maple march down to the water's edge. And it is a really stunningly beautiful place if you haven't had a chance to go up to that part of the world. Here's an aerial shot of Red Lake, and you can see that there really is not a lot of development around that lake's edge, and that it really is mostly water in terms of the geographic boundaries. Here is a sense of the American Indian reservations across Minnesota, many of which are concentrated in this Bemidji area here, but are distributed throughout the state. So I'll just briefly touch on some of the disease disparities that have existed. One interesting, I think, historical feature is that in the 1970s and 80s, there was actually a thought that American Indians suffered from lower burdens of cardiovascular disease. Some of this was related to the studies in certain populations that had indeed lower rates of cardiovascular disease, but also came from retrospective data that was incomplete through the Indian Health Service. Out of kind of a lack of high quality data was something called the Strong Heart Study in the late 80s and 90s, which took about 4,500 patients from North Dakota, South Dakota, Oklahoma, Arizona, and really did baseline exams, baseline labs, and followed them over time to characterize the burden of disease, and ultimately found that CHD here, coronary heart disease, was about at twice the rate for both men and women compared to similar cohorts. And unsurprisingly, some of the main risk factors were diabetes, hypertension, hyperlipidemia, and macroalbuminuria, renal disease. This was borne out in retrospective cohort studies more recently done in 2015. From 2015 to 2019, you could see that heart failure rates were higher in Medicare patients, about 22% compared to other cohorts. Coronary artery disease, 37% compared to 27% other cohorts amongst American Indians. And specifically, mortality has been quite a bit higher too amongst American Indians, especially with regards to cardiovascular rates of death. I'm going to get into some Minnesota-specific data, but just as a caveat, the Indian Health Service data is broken up into a few regions, one of which is the Bemidji area. It's really demarcated by the head office where the Indian Health Service is, but it encompasses a number of states. And so just to kind of give you a sense of life expectancy differences, the Bemidji area has one of the lowest life expectancies amongst American Indians compared to other Indian Health Service areas. It's 70 years. This is dated data, is kind of what I could find, but this is in comparison to the US population in general, which is about a 7-year disparity difference. The same is true of rates of cardiovascular death, Bemidji being one of the highest even amongst American Indians. And same is true of diabetes and death related to diabetes compared to the US population as a whole and other American Indian groups across the country. More specific data for Minnesota, some Minnesota tribes include a study done in the early 90s by the CDC and IHS, which showed very high rates of hypertension and type 2 diabetes. It was a survey of people of Red Lake, but also White Earth Reservation, which is in Minnesota, and the Menominee tribe in Wisconsin, and found that above the age of 65, about 56% of patients had diabetes. Above the age of 65, 62% had hypertension. So, higher rates than I think just the general population. I'll briefly touch on some of the challenges in preventing and treating cardiovascular disease. You might ask, why is there an Indian Health Service to begin with? Why is there kind of a parallel health system or an additional health system? And many of the treaties signed between the United States government and our Indian tribes involve the provision of health care and health services as a treaty rights obligation. This was initially managed through the Bureau of Indian Affairs, but in the 1950s, President Eisenhower signed the Indian Health Transfer Act, which established the Indian Health Service as a U.S. public health service to help kind of fulfill some of those treaty obligations and health spending. Now you can see here that there are huge differences even in federal health spending from our U.S. government, with Medicare topping the list of per person spending. Federal prisons even about double the rate of what we spend on our through the Indian Health Service itself. And so there are significant disparities in healthcare spending from a kind of a global overview. There's also high vacancy rates that exist within the Indian Health Service, and Bemidji area has about a 31% vacancy rate as of 2017, which is technically the highest compared to many other areas, but they tend to be high vacancy rates for healthcare workers. I would, of course, it would be incomplete if I hadn't mentioned the social determinants of health. There's a large historical legacy of oppression, colonization, deprivation, violence that underlies, I think, all of these disparities. And Red Lake specifically had quite high unemployment rates, 60%, some of the lowest graduation rates in the state, that are no doubt contributing to some of this disease burden. And I think, to give you a sense, living near Red Lake and working there for just under a year, we found that there was one grocery store on this reservation. The nearest other grocery stores are about 40 minutes away, which provides a lot of challenges to patients. Red Lake, for a lot of historical reasons, is a closed reservation, meaning no non-tribal member is really allowed to live there. And so it involves a lot of commuting for healthcare workers who want to work there as well. And no doubt a lot of challenges for patients who want to access other services. This is not only true of Red Lake, but other places like Navajo Nation, one of our largest geographical Indian reservations, is 27,000 square miles and has 13 grocery stores. And I had no idea what 27,000 square miles was, but this is what that is superimposed on our geography. And so if you can imagine only having 13 grocery stores in that kind of an area, it's a pretty punishing thing to get just basic things. But I also think that there are lots of assets of the current care delivery system and opportunities for the future. This is not just a talk of doom and gloom, that these are immutable facts, but there are lots of pretty inspiring things going on in the current system. One of which I think is task shifting. This is the notion of shifting tasks that are traditionally done by certain healthcare providers onto others to try to provide needed services. One of which is, I think, real strong pharmacy and pharmacy-led clinics. The Indian Health Service has a really dedicated core pharmacist that can have prescription power and see patients in clinic visits. There's an experience with pre-exposure prophylaxis with HIV in the Albuquerque IHS, getting people on higher amounts of medicine or on medicines and with the monitoring done by pharmacists. And anecdotally, I think the pharmacists I interacted with at Red Lake had a lot of job satisfaction from this kind of greater clinical responsibility. And they were really a pretty strong backbone, I think, for that health system in general in terms of safety and providing some clinical care. Another asset of this system is the innovative use of telehealth. Because of these geographical challenges, telehealth, I think, is a really strong tool used to try to get patients care that they need. And so one of my colleagues from medical school, Lauren Eberly, did a study, a small randomized trial, but it was looking at heart failure patients and using a nurse-led telephone up-titration system to get patients onto GDMT classes. And so she had clusters that would basically cross over into the intervention of phone-based up-titration versus usual care, which is clinic visits that up-titrate things slowly. This is a complex chart of how they managed to create algorithms for up-titration, but found very high differences in the amount of people on GDMT. We're able to get patients onto pretty much all classes of GDMT at much higher rates with telephone-based care. And by the end of this study, nearly everyone was on a beta blocker or an RAS inhibitor. Many were on ARNIs and SGLT2s, and 81% were on all 4 drug classes, just through kind of dedicated nurse phone visits. One of the benefits of the IHS I forgot to mention is that ARNIs, SGLT2s are on formulary, and so that kind of reduces some barrier for patients getting those kinds of GDMTs. And then to kind of round this out, I think tribal compacting is an interesting concept. Essentially, not all the IHS and Indian Health Services are not completely federalized, meaning that there is some flexibility for tribes to get funding directly from the US government to provide healthcare services that does not need to go through the IHS. And though this creates kind of a complex healthcare delivery system, it also creates a lot of flexibility in meeting community needs. And so, at least anecdotally, Red Lake was able to have massive drives in COVID vaccination rates through community health workers. They had mammogram initiatives to increase mammogram uptake and incentives for that. And the community health workers are really dedicated folks, I think, funded directly by Red Lake to do wound care, daily visits to patients, and kind of bridge some of that geographical divide. There are opportunities for the future, some of which have been spoken about at Grand Rounds here. We had Dr. Peter Noseworthy here to speak to us about EKG and AI, and that could certainly be used, I think, as a way to screen patients and pick up disease earlier. We see artificial intelligence in our diagnostic imaging and our cardiac CTs, and may be a useful source for primary prevention and screening for high-risk individuals. There are therapeutic innovations, inclisiran being one of them, a longer-acting medication that may help with affecting adherence. And then obviously community-led innovations and initiatives. But I think ultimately diabetes is the elephant in the room here for the major comorbidity affecting cardiovascular disease rates. And managing diabetes will involve the hard, gritty grind of delivering high-quality care consistently for chronic illnesses, for diabetes, hypertension, hyperlipidemia, cardiovascular disease. It's not necessarily like a magic bullet or technological bullet will solve all these problems. And addressing the social determinants of health is a huge and monumental task. But there are things that are identifiable, like food deserts, economic and social factors. And so I'd like to just leave you again with a sense of geography and what our role could be in this. I think the Minneapolis Heart Institute, to its great credit, through the work of Dr. John Lesser, many other leaders, Dr. Dirks, Dr. Stockman, have created a high-quality delivery system for kind of world-class cardiac care, closer to where patients live and closer to where some of our American Indian patients live. This is where MHI Baxter is in relation to some of these American Indian reservations, and I think it provides a tremendous opportunity to deliver patients care that is, modernized and of higher quality. We have cardiology subspecialty care. We have Dr. Ekman who treks up there sometimes as well. We have really a tremendous amount of resources with cardiac CT, stress echo, nuclear perfusion studies. And may be able to play a role in bridging some of this divide and helping patients get the care that they need. And I think a lot of credit should go to MHI for, I think a lot of other groups would not necessarily put a cardiac CT far away from their headquarters. And to have such a high quality diagnostic tool is, I think, a testament to this group and its geographical reach. And so I'd just like to end with this quote and ask if there are any questions. Thank you very much again for this opportunity.
Thanks very much, Krishna. Very interesting. I've never really heard a similar talk specific about Minnesota anyways. What is the, do you have any data on other preventable risk factors on the reservation? And also a follow-up to that, what are the food choices available at that one grocery store?
So yeah, I will say, to answer your second question, it's like a regular grocery store. It's got, meat, vegetables. It has a lot, a decent amount of processed foods, but it is somewhat far away from where many people live. Interestingly, there aren't really addresses for homes. People just sort of know where people live. It's small enough where people can kind of track people down, at least on Red Lake. And so the food choices are at their grocery store are what you would find, I think, at a Cub Foods, maybe a little smaller in terms of size, but pretty much the selection was about the same. And then in terms of risk factors, there is data that exists for higher rates of hypertension, diabetes, hyperlipidemia. All of that exists to some extent, but if you might have noticed, I was using 2005 to 2007 data for some of our cardiovascular disease. The Strong Heart study I cited was in the early 1990s. Survey data, again, in the 1990s for Red Lake specifically. So there's a lot of, I think, gaps in data collection. Some of it, I think, is related to a lack of historical trust with some of the research enterprise in the past. And so it can be somewhat of a challenge sometimes to collect data amongst certain groups of individuals.
Thank you very much for that excellent talk. We just have one virtual question thus far. It comes from Dr. Lesser, and it's about telehealth. And his question is, how do you see MHI interacting with the Red Lake Clinic via telehealth? And he also says both wonderful talks to both of you guys.
Thanks so much for that. Dr. Lesser, I think MHI has a really robust set of nurses and healthcare workers that can do a lot of this work in terms of aggressively getting people on medications that they need. I think telehealth is an opportunity for us to potentially see patients virtually in clinic and bridge some of that geographical divide. I think also, there's ideas of outreach for sending folks up on occasion to some of these, some of American Indian reservations to do in-person visits as well. I think that should be a possibility and could be one in the future. But I think a robust care network and trying to build relationships ultimately is what will hopefully bring patients into the fold and get them connected with the care they need. We see a lot of American Indian patients as it is. Many present to places like Sanford and Bemidji and other places and are connected with care for us. But I think if there's a real role for kind of providing a concerted effort and building relationships to try to make it easier for folks to get the care they need.
Thank you for that. Follow-up question from Dr. Hauser. He asks, so if an individual has chest pain in Red Lake, how is he or she evaluated and treated?
Yes, so this is a very interesting issue. It's one I worked on when I was there. So Red Lake Hospital has an emergency room, has the ability to give heparin lytics if needed, but often would just load with ticagrelor, aspirin, and then Sanford Bemidji, which is again 40 minutes away, is the nearest cath lab. And so lytics are a very rare occurrence. Maybe during really horrible weather, it was a necessary thing, but Sanford's cath lab, I think, has been a real boon to that community in general, and has, I think, provided a lot of life-saving care.
Thank you.
That was super interesting. Thank you for enlightening us. A number of years ago, Dick Asinger at Hennepin County Medical Center started going to the Indian Health Service clinic here in town, and he encountered a fairly substantial cultural barrier in trying to deliver care to the Native American population. I wonder if what you encountered on the Red Lake reservation.
My wife and I both had interesting experiences, and I think my wife was a primary care physician. I'll speak for her, but it took some thawing. It took regular visits. It took time to get to know patients for, I think, her to have buy-in and trust. But when they trusted her, and they really would come back for frequent visits and appointments, and would know that she was kind of in their corner. And I think I looked to her for inspiration for how that can be done, and to know that it's not insurmountable. It can sometimes just take time and effort and dedication, sometimes a little more than what cardiologists have to offer for people, but it's at least a demonstration of what's possible.
Yeah, and then I was wondering about the effects of COVID in these like food and healthcare deserts, because especially like he was saying, like with kind of the cultural differences, like how did that, like was it like worse in the Native American reservations?
I don't have good data about it. I'm sure that data does exist, but I do think that there's both potentially an outsized impact of COVID-19, but also a lot of strong innovations in terms of their healthcare delivery. And so they had community health workers and incentive-based programs to get patients vaccinated quickly and aggressively. And so there's also, in addition to maybe a higher burden of disease, there's also sometimes a more nimble ability to respond as well, because it's in some ways a single payer system that can deliver really robust care and kind of create new programs as needed as they need to arise.
Great. Thanks very much.
Thank you very much.